Good evening, everyone. Myself, Dr. Chandrasekhar. I am a Joint Secretary, ISVR. I welcome all the ISVR executive as well as all the participants. After receiving tremendous response of our first masterclass a fortnight ago about the vascular access by Dr. Sanjeev Kumar, and we'll be continuing with the same topic. And the continuation of that topic is about the catheters, hardware. And this is our second masterclass. And these masterclass have been meticulously planned and programmed by ISVR in such a way that we will cover all the essential topics right from the beginning, right from vascular access to the advances, and focusing mainly the IR practitioners, residents, and fellows. And we'll also later on we'll discuss about the case-based and system-based IR topics. Without wasting much time, I'm pleased and honored to introduce our esteemed master faculty, Dr. Mathew Cherian. He needs no introduction. He has been inspiration to everyone because not only he is a dedicated teacher, but also because of his passion for the subject. Currently, he is working as a director, Intervention Radiology Kovai Medical Center, Coimbatore. He is a past president of ISVR and current president of STNI. He has many publications in index journals, delivered innumerable lectures, talks, and conducted many workshops on various national and international forums, and has also won many awards and accolades. Sir also runs fellowship and DNB programs on IR, which are quite popular among residents. Now, today we will deliver a masterclass on hardware, which is very much essential, especially for the residents, where you will cover all the catheters, guidewires, and hopefully you will try to be more practical than it will be like an interactive and practical approach. Yeah. And sir, over to you, Dr. Mathew Cherian, sir.
Okay, so today we are going to do something which is quite different from what you would have probably seen or heard, because we decided to do away with PowerPoints and try to do the whole thing by using, actually, we thought we'll try to, sorry, just 1 second, try to actually use actual catheters to, try to do, show you what really happens, and I hope it works for you, okay? Just move it. Oh my God. It's funny about this. Doesn't stay straight.
Yeah, it's not touching itself.
Okay. I'm just sorry. We tried something and it was working foolproof, and then okay, fine. This should be fine. Okay, so I've been asked to talk on guide wires, on catheters, and guiding catheters. So as the name indicates, a guide wire basically is something that will be used to guide something else. And what does it guide? The guide wires are used to guide sheaths, guide diagnostic catheters, guide the guiding catheters and micro catheters. So the first guide wire that you may technically see will come in a sealed packet like this. And these are guide wires that are part of a sheath. Okay. Now, this has only one single use. And that one single use is to enter the vessel after a puncture. Okay, you can see that here. So it has got a loading device. It has got a J-shaped tip over here. And we actually, what we do is, we would puncture the vessel, then push this out and enter the vessel, right? Once you're deep to some extent, you will take this out and you will go ahead and put your sheath. Now, it has got a straight end also, So it basically gives you the opportunity to use a straight wire or to use the J wire. Now, in general, we never use a straight wire because a straight wire is dangerous. It can actually go subintimal. It can cause a problem. Have you got this? So because of these things, we actually do not use a straight wire, but a J wire. So this is basically the starter wire. But in real life, we do not see too much of it as in a cath lab because we reuse sheets. Once we reuse sheet with guide wire, invariably is not packed and it is gone. And because of that, we use a standard J wire. Okay, we use a standard J wire. Now, let me show you each of these products. Now, the standard J wire is this wire. This is what you will see. It is 150 centimeters in length. Comes with a loading device purely because it will allow you to give the safety curve. And this is the wire that we would actually enter into the blood vessel. Now, I want to show you the property of this wire. This wire is green in color. I don't know if you can make out, but it is green. Maybe if I put a white background, you can make out the green color. As you can see, the green is because of the Teflon coating, which makes it less thrombogenic. Okay. Now, this wire is not a great wire for anything except the safety that it's there because of a J wire. Because if you bend this wire like this, you see what happens? It goes bent. Can you see that? This wire is destroyed. Another problem with this wire is, now I'm going to open this wire completely. And if I torque this wire, I'm torquing this wire, nothing turns. Can you see that? The wire doesn't turn at all. So it has a zero torque wire. It is basically made with a combination of a coil like this inside a stainless steel core. Okay. It's a coil on a stainless steel core. If I actually stretch it, the coil will stretch. If I cut it, I can take this out, and this sometimes is used to make coils. You know, when you make coils in the lab, you use the outer part of this or the green part to make coils. So it comes, like I said, in 150 centimeters and 300 centimeters if you want to do an exchange procedure. So it's again a wire that we use initially for access. But there are a few other uses of this wire. For example, if you're coming down an artery with a lot of branches, if you take the J wire, it will not enter the branches. Sometimes we use it in our department when we pull the SIM one down from the arch. We created a curve in the SIM one. As we pull it down, we bring the little bit of the J tip out so that it will not get engaged in the vessel and it can be a little fast, right? So otherwise, you need this wire as the initial wire. You cannot survive without this wire in the cath lab. But having said that, like I said, after the initial access, you may not have much use for this, right? Now, I showed you this property of this wire as a wire that kinks, right? I said it kinks. Just see that? I bend it like this. It is gone. Can you see that? It's a destroyed wire. So, this is because of the metal that forms the core. There is another material that we use, and I said this is stainless steel. The other material that we use is called nitinol, right? Now, you must remember nitinol, because nitinol is a material that has revolutionized interventional radiology completely. This wire out here is got a slippery coating because nitinol meets the slippery coating, which is hydrophilic. It's basically methyl methacrylate. When you put water on it, it absorbs water. Now, what is the property of this wire? There are many things in this wire which is not available with the routine wire. So first property is, if you torque the wire, it will torque. See, I'm looking at this. See, I'm turning this. Can you see turning? See the wire? As I'm torquing this, it turns. It is called a 1:1 torque. Now you may say that, okay, that's not so big, it looks straight. But interestingly, even if I take these two loops on it and torque the wire, it would still torque, you know. Can you see it turning? Actually, a problem is I don't have a torque in my hand. By mistake, I didn't get it. And my hand is slippery, but if you look at it, it actually, I'll try to get you a torque, my mistake. And you can see that even across the bend. Can you see torquing? Okay, that's actually Santosh helping me out. He's helping me to make it drier. Okay, can you see that? The tip will torque even across a bend. Can you see that torquing? It takes these curves. Now, that is extremely good. That means in however torches the anatomy, this tip will keep torquing. This tip will keep torquing, okay? Right. Now, look at another property of this wire. Okay. Now, I'm taking this wire and I'm bending it. Okay. Can you see that I've knotted it? On top of that, let's now knot it to the craziest level we want. Have you seen that? We do anything to this wire. Can you see that? I mean, you can't really do more than this to a wire inside, but you see that it comes back to total normal shape. That is the property of nitinol. Have you got it? So today you understand this has got tremendous capabilities just because of this. Now, nitinol is basically made of nickel, N, titanium, T, and the Naval Ordnance Laboratory. So it was initially made by the Naval Ordnance Laboratory. Now, so if you're doing a subintimal angioplasty, you'll create a loop like this. Okay, the loop forms like this. And as you push it down, this loop gets bigger and bigger. But when you pull it out, it comes back straight again. Otherwise, you cannot do a subintimal angioplasty. When you use a straight tip wire, you can use it very well to cross occlusions. Even this can be used to cross occlusions. Because of the capacity to torque, it is very easy to super selectively enter blood vessels. You get it? So this is the most important wire that you will use in the cath lab, a nitinol based wire. I'm going to talk more about wires and properties. So you don't need anybody to tell you, you try to bend it like this. Nitinol means it will never ever bend. Have you got a kink resistant wire? Now what they have done, this was initially developed by Termo. They have got many different thicknesses. It comes in the standard size, a 3-5 wire. They got an extra stiff Termo wire. They got a shapeable tip. Now the problem you understand, because of nitinol, it's very difficult to shape this tip. The tip won't shape. So it comes generally pre-shaped. But they have created a little bit of help to allow you to shape at the tip. You can see I tried to shape it, but it's not a very great shaped retention. And remember also that this is not a very radiopaque wire. So when it comes to some places, we create a fusion wire called the hybrid wire. I'll talk about that. So hope you understood this is a workhorse wire needed. You get it in 3-5, you get it in 2-5, you get it in 1-8, 1-4, all the way. Now, never go by the color. For example, now look, if I wish I could sit with you and I would ask you this question. This is a wire that is white in color. See, I'm going to put it across. Yeah, can you see that white wire? I'm going to bend it again in the same direction like I did before. Can you get it? And it opens out. So what is it? It's a nitinol wire. So the two important wires that we have in the cath lab is a stainless steel core wire, which will kink, which will bend, which will become destroyed, and a nitinol wire, which will never kink, will never get destroyed, can torque 1:1, and can be used for subintimal angioplasty, to cross occlusions, and also to do super selective catheterization, right? Okay, so I hope you got it. But remember, this wire comes with a hydrophilic coating. It has to be wet. If the wire is not wet, it will get stuck inside your catheter. So remember, it's extremely important that it has to be wet. Now, this is the Roadrunner wire from Cook. You don't need to know the name. You know it's a nitinol wire. Can do everything exactly the same as the Termo wire. Okay. So there are other companies. Asai is also now making catheters wires. So we talked about materials. We talked about a J-tip wire. Now we talked about wires. How much support do they give? Now, if you looked at the previous J wire, if you put it straight, it would not remain like this. I'm just going to show it again. This was the J-tip wire. And if you look, the tip is very soft. You just touch it and it bends. But whereas this wire, you see, it's really stiff. So this is called the Amtlad's extra stiff wire. It can have a tip that is straight. It can have a chip that is J. It can come in a standard 150 length. It can come also in a 300 centimeter length. Now, what does this do? When you enter a vessel with a catheter, and if you pass this, it will straighten the loops. A very tortuous iliac will become straight. A tortuous carotid will become straight. Not only that, because it straightens the pathway, it also allows catheters to track much better. So we would use it in a tortuous anatomy where the diagnostic catheter is already gone. Now you want to take a thicker device like a guiding cath, or you want to take a crossover sheath. then you will require an extra stiff wire. And sometimes the commonest place we would use it, for example, we are doing a carotid stenting, we put the diagnostic catheter external carotid artery, then we would take this wire into the external carotid artery, pull up the diagnostic catheter and take the shuttle sheath. So we need extra length, and so we use exchange length catheter. So in our cath lab, we do not have super stiff wires in regular length. They are always extra exchange length, purely because of this fact that we would use it for many, many exchange maneuvers. Doing a crossover procedure, doing an angioplasty, we would push the extra stiff wire down the catheter, then take a crossover sheath across it. Or for the matter, you want to put a long sheath into the carotid for a neuro intervention, it's always the same. So this is called the extra stiff wire, but remember this will kink easily. If you bend it, it will also go because it's a stainless steel core wire, right? I don't feel like destroying this wire because it's such good condition, but believe me, you kink it, it is exactly made like the J wire, only the central core is much stiffer. It has no torque, but all it has got is just a stiff core which gives support, fine? Now, what if you want to take a thicker device? A thicker device, for example, you want to take a stent graft. In those, you'll have wires that are even stiffer. So this is called the Amplat super stiff wire, even stiffer. Remember when you use this wire, just remember one thing, if you're doing a crossover procedure, you're gone in the opposite femoral and deep down, don't pull the wire directly out, it can cut the iliac artery at the bifurcation. Always pull the wire which is inside a catheter, because these, when they bend, they can really be tight on the bifurcation, okay? So this is the Amplat super stiff, and even stiffer than this is a wire called the Lumberquist wire. Have you seen this? Look at that. It really is hard. Actually, if you just jump out of your hand, you see that it just straightens up like this. The Lumberquist wire is the stiffest of all the wires that you can get in interventional radiology. Its exclusive use is for aortic stent grafts. We put this curve, sometimes we'll enter into the left ventricle with this curve, but when we do an arch repair, we need this to be this way. See, understand what I'm trying to talk? It's got to be like this in the arch, you get it? Okay, it's a mirror image, so I want to turn it around for you to get it. Okay, here it is. So this is in the arch. This will open the arch up, gives the support for that, you know, the 25 French device to track. And the Lumberquist wire is a mandatory requirement for you if you're doing aortic stent grafts. It's a mandatory requirement if you do aortic stent grafts. Got it? So this is the Lumberquist wire. So to summarize, we got a J wire, which is a safety wire. It is a stainless steel core wire. It kink, has very little use except access. Then we got the nitinol wires, which can be angled or straight, which are very torqueable, which is the most popular wire in the lab, used for recanalization and also for super selective catheterization. Then for support, we got the extra stiff, the super stiff, and the Lumberquist wire, which is the father of all wires when it comes to stiffness, right? Okay. Just wanted to show you another small thing before we go. Huh? Now, what if you want to get a wire that is not so stiff, but yet somewhat stiff, and then you can use a wire which is called the Rosen wire. This wire is called the Rosen wire. Can you see the tip? It's a J wire, moderately stiff, and we use it very often for doing a renal artery procedure, especially if you're doing a fenestrated graft. You want to take a stent graft into the renal artery. This is what we would use. Okay, this is what we would use. And this is called a Rosen wire. If you're doing some procedures like that, do keep a Rosen wire with you. It's a J wire. Just trying to show you. Okay, let me show it again, this here. And it is like a super stiff wire, but not so stiff. And then it's not got such a long floppy end. So remember, when you take a super stiff wire, if the floppy end is too long, and you're doing a renal procedure, what's going to happen? Simple logic. The floppy end will be outside the renal ostium. So it's functionless. So the Rosen wire sort of is a good hybrid wire for this. Wires, like I said, can also be, what's the next wire? Now, these wires, like I said, also can come in thinner calibers. Now, this is called a V18 wire. Have a look at it. You have to tell me what the tips are made of. This looks black. This looks like steel. If I take this tip, I'm just going to use my hand and bend it. It's got bent, right? Bend it further. It's got bent further. Can it be nitinol? It cannot be nitinol. Have you got it? Why do you know it's not nitinol? Because is there a shaping tool here? I just want to use a shaping tool. Just show me a needle or something. Now, suppose I take something like a needle and run it, you'd see the wire will get totally destroyed. Can you see that? Sorry, can you see what's happened to the wire? Completely gone, right? Have you seen that? Just have a look at it. Completely destroyed. And that shows you clearly that this wire tip is not nitinol, right? So it's very easy for you to understand. So when you're using these wires, remember, don't use this wire like a V18 wire, the tip which it shapes in a total occlusion. Because you try to cross it, this will become like a knot and it is absolutely useless. Got it? I don't want you to remember names. I want you to understand this property so you can decide what's best. But it can work well in a stenosis. Where you can pass through the stenosis, come to the other side. It's got a nice support, you feel it, and you know that this will work, but not for a total occlusion. This is actually a V18 wire, but it's a property. Now, this wire is called the command wire. Command wire is made by which company, Santosh? Command is basically from Abbott, is it? Yes. So Abbott makes the command wire. Now have a look at this. I'm taking the needle again, taking the tip again and shaping it. Can you see that? Can you see? Hardly any change. I have to try hard to get that little shape. Can you see that? What is the tip made of? Simple, right? The tip is made of nitinol. So now this wire is a great wire if you want to use for total occlusions or Belloni vessels, because this will not get knotted up, will not kink, and you can use it. But the problem with nitinol doesn't have support. So what these people have done is they have taken this wire and they fused it to a stainless steel wire. Now, can you see the change in color? I'm going to put it again in my shirt. I hope you can make out. Can you see the change in color? It is changing from, a dark segment here to a white segment here. Okay. And now this portion, if I bend, what happens? See, it is changing its property. It is kinking. Can you see that kink that is developed? Can you see that? You can see that kink, right? So now you understand this is a hybrid. What they're taking a stainless steel wire to give us the support that we need of a stiff wire, fused it onto a nitinol wire here. And actually, if you do a lot of manipulation at this might sometimes break. So sometimes when you do a lot of torquing, the tip is not moving, this can break. So this is the junction. Okay, this is the junction where the nitinol component fuses with the stainless steel component, and this is called a command 14. So these wires are extremely good wires for working on Belloni vessels. They torque well, they support well. It's a fusion between a steel wire and a nitinol wire. Okay, a steel wire and a nitinol wire. And even more amazing is a wire called a synchro wire. Can you see that synchro wire? Okay, it's a very thin wire used for neuro procedures. What is beautiful about the wire, it's a total different construction. The wire basically, unlike all, has got a nitinol sleeve, not a mandrel. Because it's got a nitinol sleeve and a platinum tip and a steel mandrel, the wire is very torqueable, very soft, extremely good, and is very good for neuro work. But what is the problem with this? The tip is very difficult to shape, because once the nitinol comes as a sleeve, it's not easy to shape. But a great neuro wire, and now actually synchro is going to come with a much better shapeable tip, and that will change this. So look at it. It's again a great wire. It's built on a nitinol platform and it's called a nitinol tube, right? So this is a basic idea about wire that I've given you. Just try to make you understand the basic property of nitinol versus steel. Nitinol is a great wire for torque, no kinking, less of support, make a hybrid wire. It works well. We talked about a V18 wire is a great support wire, but the tip will kink. Versus a hybrid wire like the Command 14 or the Command 18, which works very well in the periphery, versus the wire which can work in the brain. We can have actually hybrid wires in the brain also. For example, Bart gives a wire called hybrid, and for the matter, Traxxas is again a hybrid wire which is created by Microvention, which is a thermo company where they fused again steel with nitinol. So I hope you got an idea about how Guidewires work and how they are created and how they are made. Okay. And also remember that's why you choose well, and all companies, that's why I like to use these fusion. The core may be made of platinum, the tip coil may be platinum to make it radio opaque, because nitinol wires are not radio opaque. Okay. Okay, I hope you got an idea on why you need what, why you need extra strip wires. From there, let's go to diagnostic catheters. Now, if you see a diagnostic catheter, they are basically made of polyethylene or a polymer of polyethylene, and this is a diagnostic catheter. I don't want this time to look at the shape of the diagnostic catheter, just the property. Now, diagnostic catheters at one time were notorious for one thing, and that was for breaking. So look at this catheter, and I'll just tell you how easy it is to break this catheter. I'm bending it here. Maybe I should just turn around so my shirt comes in the front. Okay. Can you see it? I'm turning it around. So in the real life situation, you're doing a case, you're moving around, you're not noticing you have formed a knot over here. Not only a knot, this catheter actually can even break like this. See that? Have you seen this catheter? I'm going to ask ISU to pay for this catheter, but you look at that. This is horrible. Can you see that? You leave this catheter behind, and that is going to be a disaster. So today, very, very rarely do have unbraided catheters. This catheter is basically a fusion. A part of it is braided, and the tip was not braided just to make it very, very gentle to enter the uterine artery. But by and large, all the other catheters that you see are braided today. Now, what is the advantage of a braider? So they will have a stainless steel braiding in most cases. Sometimes they can even use a nitinol braiding. So just look at this, a diagnostic catheter again. Okay. And just change it in a way. So, okay. So this is a diagnostic catheter. See that? Okay. Now I do anything to this. See, I turn it, I twist it to any shape. Can you see that? It's completely twisted and gone, but you can't break this catheter. Can you see that? You know, with all my strength, I will not break it because this has got stainless steel braiding. So I'll ask Santosh to give me a scissor. There's a scissor here. Okay, let's try cutting this catheter to see further, you know. So now when you cut this catheter, it is not easy. We cut it this way. And if you look inside, you can't show it to you, but it's really sharp because of the 16 braids that they have. So braiding has an advantage that it won't kink, it won't break, it can kink. It also makes the catheter very, very pushable and torqueable. So torqueability also is a lot more. Turn this around and it will torque like crazy. Okay. The next thing about catheters basically is the properties of the catheter in terms of what guide wire can go, what is the length of the catheter, and so forth. For example, this catheter, can you see, it's got 4 written on it. So what does that mean? It's a 4 French catheter. Let me see if you can see any better if I come closer. Little difficult to focus this, but there are some other statements on it, like 038 is written on it, which basically means that we can't, I think it gets totally out of focus. Okay, so it means a 038 wire can go on it. On the other side, there's 100 written over here, which you can't read exactly, but it's right here, which tells you it's 100 centimeters. Now, so remember, in the catheter hub, there are many things written. The French size, the pressure, the length, and what is the kind of wire that will go through it. Okay. Now, for example, here's another catheter made of merit, and this has got if you can read it, but if you can read it, you can see it has got something written on it. And like, you can't see it. I know it's 4 French, and it is 125 centimeters in length, and it takes a 038 wire. So remember that, look at the tip of the catheters if you have doubt. It will tell you different lengths. It will tell you the properties. Very, very useful the way you do it, okay? So that's a little bit about length of catheters, the wires that will accommodate, and also, like I said, the French. Let's go into some shapes. The commonest shape is this shape. So what is the shape? This shape is called a pigtail. This shape, although I call commonest, probably everyone remembers it, we don't use it too much, but it is used for a flush autogram. But not only can it be used for a flush autogram, but it can be used for some other interesting purposes. For example, if you want to cross the bifurcation of the aorta, you can also try this. You know, what you do is, you go from this side, you enter, and show me a guide wire, please. And I'll just try to show with the guide wire what happens. Can you give me a thermo wire? It's lying down here. Just one second. If we take a wire, this will actually have to wet this and right if I can. Let me see if it works for you to show you what happens when you put the wire inside. So what happens is it actually opens up. So if you take this pigtail and you pull it down on the bifurcation, it actually opens up a bit like this. And then if you push the wire, it can cross. We tend to use something as simple as a Bernstein, but remember this can be done. Then another place where it finds great use is if you're coming from a transradial or you're coming from the brachial approach. Again, if you turn this catheter around to face outwards this way, sorry, yeah, if it is facing this way, and you push the wire out, you get this idea? When you push the wire out, it is going to come out into the arch, okay? Right? So you understand it comes this way, so it can actually enter into the descending aorta because of this property, right? It can come into the descending aorta and you can push it out. So this is another use of the pigtail. So there is just a few uses that you can do beyond the classical flush autogram. Now pigtails also have another interesting configuration, which we call it as the marker pigtail. Can you see that here? The marks on it. These are 1 centimeter apart, and you can see probably better when I move it to this side. Okay. Now this is used for measuring. Classically for aortic stent grafts, you want to know what are the length from the inferior renal artery to the aortic bifurcation or to the iliac bifurcation, or for what is the length you needed for the thoracic aorta. So it's just measuring scale. And a very important catheter if you're doing any procedure where you need to measure. Okay, so just want to let you know this is a marker pigtail, right?
Angle.
The third pigtail catheter is an interesting pigtail, which is called the angle pigtail. See that? What is the use of the angle pigtail? If you're doing pulmonary artery angio, you enter from the IVC, go up, turn it, and when you torque it, rotate it round, you know, it actually looks up like this, and you push it up, right? So this is very useful for a pulmonary angiogram. So it comes this way, like I said, comes up, and you can push it up, and it goes all the way up, right? So this has got an angle, which is very helpful. So when you're doing, actually, you go like this down, right? Comes like this. Then you make it look up by torquing it. Sorry, this is maybe it's getting stuck over here. Yeah, it is then, and you push it up, right? So this is called the angle pigtail. 3 pigtail catheters: the standard pigtail, the marker pigtail, and the angle pigtail catheter, right? Another catheter that we use very, very commonly in our lab is called the Bernstein Curve. Look at that, just a simple 90 degrees. Now, this is one of the most useful catheters that we find in our lab. Many people don't seem to use it, but believe me, it's the best multi-purpose catheter. You can enter the carotids, you can enter the subclavian, you can enter the vertebral, you can come down, you can enter into the crossover, into the bifurcation. You can also use it down profunda, femoral artery, tibial arteries. So it's a great multi-purpose catheter for many, many things. It works like an angled wire, and we use it extensively for all our work. And I think in our department, this is the most popular catheter that anybody can use. You can use it for pushing coils because it just got a single lumen at the end. You can use it for injecting particles. So generally a great catheter to have in the lab. And like I said, can be used in many, many places across the body. A catheter that is again available is called the multi-purpose, but is actually one of the most useless catheters. I don't know why they call it multi-purpose. We hardly use it for anything. But remember, if you come from the arm, you can use it for entering into the iliac arteries. Other than that, we rarely use this catheter, but it's called the multi-purpose catheter. I really don't think it's one of the more catheters that you even need to keep in the lab. Another very useful catheter is called the Simmons one. Look at the curve. It looks like this. When you go into the body, it's going to look straight like this, right? You can't enter with a curve, right? It's going to look like this. You enter inside the body, it goes into the arch. Either it enters into a branch like this. Actually, the mirror image. I'm just wondering whether there's some way I can change the mirror picture direction somewhere. Is it possible? I don't know. Yeah, you go to settings, it'll take time, but it's a little more confusing because of that. Okay, just look at it. So it's like this, it goes straight up, you get into the arch, and then you torque the catheter to get the shape, or you enter into a branch and you push it to get the shape. Now, this is a great catheter. Why is it a great catheter? Now, imagine that you're entering into the arch vessels, pull it up, it goes into the carotid. Take it a little deeper, pull it up, it enters into the subclavian artery, or you pull it up, enter into the right carotid. So it's a great catheter for arch vessels, but it's also a great catheter in this shape to enter bronchial arteries, intercostal arteries. Come a little inferior, look anterior, it's a great catheter to enter the superior mesenteric artery, right? The superior mesenteric and the inferior mesenteric and the celiac axis. All three, celiac axis, SMA, IMA. It's also a great catheter to enter the opposite common iliac artery. So this again is a brilliant catheter which you have to have in the lab. Neck vessels, visceral vessels, lumbar arteries, intercostal arteries, bronchial arteries, renal arteries. So great. So this should be called also a multi-purpose catheter in some form. Great catheter to have. Remember, if you got just an AP plane, just remember when you torque the catheter, if you torque clockwise and the tip moves clockwise, it is an anterior tip of the catheter. If you torque and it moves in the opposite direction, your catheter is posterior. Just remember that. So it's a simple way to remember, understand your AP or lateral, especially when you hook the celiac axis and the anterior vessels of the aorta. The next catheter is called the SIM2. We showed you this catheter. This is just the larger version of this. What the advantage of this? The aorta is broadly unfolded. This is what you use, right? So again, what happens? You rotate it around and you can enter the arch vessels, right? So come this way, mirror image. So come and you'll enter this way, pull it down, enter this way, right? It's a great catheter. But remember, this is the catheter that you'll use for accessing neck vessels when you come transradial or transbrachial. This is the catheter you'll use when you come from the arm to use this. Good. Do you understand? So I just want you to understand this point, that very important to have these catheters. You cannot run a lab without the SIM1 and the SIM2. If you want to do transradial procedures, you need to have the SIM2. Otherwise, you cannot enter any arch vessel. All the vessels, subclavian is a direct axis, the right carotid, the left carotid, the vertebral, all of them can be, the left vertebral, all of them can be accessed with the SIM2 catheter. The other catheter, of course, is the other visceral catheters. Believe me, if you have a SIM1 or SIM2, you don't even need them. This is basically called a Cobra. I think it's a cobra. It's a cobra which is got a shape called a C1. Okay, looks like a cobra. Can enter visceral vessels. You can enter intercostal vessels. You can enter bronchial arteries. Any of them, right? So it's your choice. You can choose one of them. You can work like a Sim1 in the aorta, except that it's not a catheter for the arch vessels, and that's why they are made it a short length. These catheters are just 65 centimeters in length because they are not meant for the arch. Another catheter that we can keep in the lab for some special purposes is the shepherd's crook. What do we use it for? Rarely we use it to cross the iliac in a total occlusion. So we go across, and then after that we can probe with the wire and try to cross a close occlusion. Not a very commonly catheter. You don't really need to have it. Another catheter we use very regularly is a catheter made by Terumo called the Yashiro. It's a three-dimensional catheter, very good to enter the celiac axis, the SMA and the IMA. The advantage of this catheter is if the catheter tip is facing the left side of the patient, we know that the tip is anterior. If it is facing the right side, we know it's posterior. So it's very easy to know anterior, posterior just by looking where the tip is, left side or right side. Great catheter for chemoembolization, for entering the gastroduodenal artery. And so we use it a lot for the viscera. Honestly, we love this catheter and use it very, very often for taste. Invariably, this is our first choice. Another catheter that we can use is also the uterine artery catheter. Have a look at this catheter. This is called the uterine artery catheter. So how does it enter the body? It comes straight like this. Because of the curve, you can cross the bifurcation. Once you cross the bifurcation, it goes down. It forms this curve. At the point of curve, you just push it up. So the catheter goes up. Now you can torque it and bring it into the internal iliac and pull it down, enter the uterine artery and finish your embolization, or the anterior division and finish your embolization, go up, rotate it round all the way and bring it down into the ipsilateral side. So what's the advantage? You can enter iliac arteries from the same side. You can enter iliac arteries from the same side, okay? And I just want you to understand it's a great catheter for something like this. So I want you to keep this in your lab for a PPH, because already the patient is hypotensive, getting punctures are difficult, for a uterine artery procedure, for a prostatic artery procedure, for anything in the post-trauma after a pelvic fracture, all of them work great with a Ann Roberts uterine artery catheter. But remember, don't keep on torquing this catheter. Inside the body, what will happen is this will get knotted up. You know, this will keep getting, I'll just show you what really happens. Keeping it like this, if you keep one tip in, what's going to happen? It's going to get knotted like this. See that? And then finally, you will not be able to take out this catheter. So always look for every 2 torques, untorque it so you don't get into trouble. Okay? And that's the uterine artery catheter. It's a hybrid catheter. The tip of it doesn't have any braiding, but the proximal end is well braided to give us a very good torque. One last catheter that you should know is this catheter. This catheter is the transgradial visceral catheter, right? And this one can come from the arm, and then you can enter into any visceral structure. It's simple to understand, right? It comes like this, and then you can actually go inside, enter the celiac axis, the SMA, the IMA, or wherever you want to go, right? So this is the catheter of choice for doing visceral vessels from the arm, and the length of it will be 125 centimeters. Before I leave, I just want to show you 2 catheters which mostly radiologists don't think about. One is this catheter, the Judkins left. But you know, it's a great catheter sometimes. For example, you want to engage a bronchial artery arising from the arch and nothing fits in. Take this up, this open is so tight, it'll just fit onto the arch, right? So remember, for some difficult axis, where you want a very good counter pressure onto the arch, you can use the Judkins left for this. So we use it for those unusual locations, right? Like you want to enter into the situation where a branch is there in a dilated aorta, you still can use the Judkins left. And of course, the Judkins right is a catheter which basically, this is a guiding catheter, It's a catheter that looks like this, which basically is used for like a Bernstein. Many people use it instead of a Bernstein, right? Just looks very similar, like a hybrid between a Bernstein and a Cobra. From here, we will go to a set of catheters which are called guiding catheters. Why do you call them guiding? Because they guide. What does it guide? The lumen of this catheter is much, much larger. It will be written on it, or it will be written on the cover. Like this one is a JR 4.0. I mean, the JR4 6-French catheter. It's got a much larger lumen. The cover will write the lumen size. This is meant for taking a coronary wire and a balloon. But in the neuroanatomy, the sizes are so large that we may take larger and larger bore catheters. For example, if you have got a 6-French guiding, double lumen, we can take a balloon and a mitral through it, right? So these are the guiding. They come in many different shapes, and the guiding catheters are soft in the distal part, braided proximally to give support. But slowly, guiding catheters are going out of vogue, and I'll tell you why. When you come to the renal segment, we use a shorter guiding. Can you understand? So remember, this is a 6-French guiding. The lumen will be 0.60 of an inch, and it will be written clearly minimum internal diameter for a stent. And you have to match that diameter when you take. So most of the stents will actually go through a renal catheter. This is basically RDC 071. It's written right at the hub. And so basically it will be written clearly the diameter is required to take a renal stent and match it to this lumen, otherwise it won't go. So these are the guiding catheters. Look at the shape. It is made to go into the renal artery, right? So we will use this to enter the renal artery, and this is a renal guiding catheter. Now, these are the modern guiding catheters. We don't call them guiding catheters actually. We call them as distal access catheters. Now, this is basically a catheter which is called a neuron. Now, the neuron is an interesting catheter. These are complex because these are made like tubes, so the extrusion technique. Complex braiding is there, and the braiding can be steel or nitinol. Nitinol makes it kink resistant, steel makes it more pushable. It's easy to know the property by just bending it. Now, if you take a catheter and you bend it like this, and it gets destroyed like this, remember, this is not nitinol, this is steel. So remember, if you got a nitinol, a steel-based catheter, this is a neuron, and you take it across a tight loop in the carotid artery, this is what will happen. But on the other hand, the anatomy is not too complex. This is a great catheter, right? So this is called the distal access catheter. This is a neuron. These are much more atraumatic than the guiding catheter. Has to go through a long sheath. You cannot push it directly from the groin. So the long sheets we can have are the neuro long sheets. Somebody I'm sure will be talking about it, which are called the Neuromax or the Infinity or Cerebros or whatever. But the bottom line is they are extremely good catheters for neuro work. And these are the distal access catheters, and this is the neuron. Now, I want to show you another distal access catheter, which is called the Navion. Now, Navion is made by another company, which is called Microvention. And again, look at this. Again, looks very similar, but when you rotate it, you see, and you bend it like this, it does not kink. Have you seen that? I did the same thing, mess of it, but it opens out. Very simple to understand. What is this made of? Nitinol. So this is a nitinol braided character, Navion. So we tend to use it a lot more than the neuron purely because it doesn't kink, right? Very simple for you. I'm just showing you this to make you understand how property will depend on the material that they use for braiding, right? Stainless steel makes it pushable. Nitinol doesn't make it kinkable. If you put helical braiding, the advantage is that it won't collapse. But to put cross braiding, the advantage, it makes it more pushable. So remember, again, depends on what is the braiding, but all these have got multiple zones. A very stiff zone here, a slightly softer zone here, even softer zone here, and a very soft zone in the end. And that's what gives it the property that distally is atraumatic, proximally it's pushable. And some of these have got 5 zones, and there are some where there are infinite number of zones, and that's why they're expensive and very, very challenging to manufacture. One of the greatest, probably, and the most trackable of the distal access catheter is a catheter called the Catalyst. This is made by Stryker, and this one is a 5-French catalyst. can take very complex bends, and you can see this. I do all this and do it, and it opens out again. See that beautiful? So what does it mean? It's made out of? See, imagine real life. I've got a very tortuous carotid. I'm bending all over the place, still open, still not kinking, and I can get it out like this, still in shape. So this is called a catalyst, one of the greatest catheters you can get for distal access, right? So these are large bore catheters. Depending on the inner diameter, you decide what is the material that will go through it. A few words on microcatheters. The microcatheters go through the guiding catheters or the distal access catheters. So in the periphery, we use a few microcatheters. Now this microcatheter is made by a company called Asai. Okay, Asai is a Japanese company, and the name of this catheter is, I just forget the name. What's it called? Asai's catheter. So basically, they come in 2.1 and 2.5 for the peripheries, in lengths of 125 and 150. They work just like any other microcatheter. They all got nitinol braiding. How do you know it? Just bend it around. See this? Simple logic. Rotated, does it kink? No, it doesn't. It is nitinol. If it kinks, it's steel. And obviously, we don't want a kinkable microcatheter, right? So this is the Asai's microcatheter. It's called a Parkway. And basically, remember, this is a great microcatheter. So in our lab, we just keep two microcatheters, the Asai microcatheters and the Thermo microcatheters. Both come in lengths of 125 and 150 in 2.5 and 2.1. So the 2.1s are the ones, the blue one is actually the pro grade. So the 2.1s are good for injecting coils. You can also go more distally. Also very good for injecting materials like 100 micron particles or 200 micron particles, and also for injecting radioactive beads, right? So remember, it doesn't matter you remember the names or not, but remember from our side, it is Thermo and Asai that we use most commonly. We seem to like them the best. They are basically, all of them are made out of nitinol. This thing. See that? We just rotate it in any form, bend it in anything, crush it like this, and take it out, and the catheter shape is retained. And that is what makes them extremely good catheters. You don't have to worry about getting kinked or things getting stuck into it, right? So we have got, like I said, in 125, and this is again a same thing in, this is a 2.1, the pink hub, and the other one with the blue hub is actually 2.5. So this is a 2.5, this is a 2.1, this is longer, this is shorter, it's all written on the cover. You won't have any problem, right? Now, this is the neurocatheters. The neurocatheters are usually 1.4 or 1.7. Remember and check whether two things. Is there one tip marker or two tip marker? If it has got two tips like this, it means it's meant for pushing coils. If it has got one tip, remember, that is for injecting liquid agents. Now, when it comes to liquid agent, always check, is it DMSO compatible? Because if it is not DMSO compatible and you inject, the tip will melt. For example, Headway is DMSO compatible. Or for Marathon is DMSO compatible. Sonic is DMSO compatible. These are all the microcatheters we use in the brain. Whereas Magic is not DMSO compatible. So always look at the cover, check it's DMSO compatible or not, right? And so there are lots of companies. This is called SL10. All of them are nearly the same. These are microcatheters that you can even shape the tip. You have a steel mantle, give a bend, steam it for 10 seconds, and you get a shape. Okay. So these are shapeable microcatheters which can be used primarily for treating intracranial aneurysm, right? And then we got the 21 and 27 catheters for many companies. This is called Phenom. You got the headway 21, the headway 27. These are mostly used for putting 18 coils. Stent retrievers from different companies. For example, a 4 mm stent retriever will go through a 2.1, a 6 mm will go through a 2.7, but that also has changed. The modern solitaires will go through 2.1 for whether 6 or 4. So do check, and you remember that you got up to 2.7 in these microcatheters, which are useful for basically doing different kind of procedures. All of them will be written on the hub. For example, this is written as Phenom 2.1. You may not be able to read it, but it's right there, and you should read it, and that lets you know how compatible it is for another device. For example, this is a company called Phenom, and this has got 27 written on there. You can't read it, I know, but the bottom line is that it is right there. So that's a kind of a summary. We got 1 hour. We've just completed 1 hour, taking you through a summary on basics, simple concept of wires. Are they J wires? Are they angle wires? Are they non-angle? Are they nitinol wires with torque or do not torque? The hybrid wires, which are probably very good for many, many uses. We went from there to a series of diagnostic catheters to tell you different shapes and they're braided or not braided and how you should use what. And finally came to the guiding catheters, the access catheters or the distal access catheters, and the mitral catheters. So with that, I just hope you sort of like this talk and enjoyed it. We thought of making it different from the usual master classes, which are just basically slides, with the hope that you can sort of understand a little better in the short time that we had. So thank you,
sir, for your wonderful lecture, and it was really fascinating, and all the points were apt and practical, and it would help immensely all our participants practicing IRs. I can see even the stalwarts of IR attending our master class. And now forum is open for discussion. Any Q&A. There are few question and answer which are being typed, sir. Difference between Lumberquist and extra.
Somebody has asked one question.
Yes, sir.
That is honestly, Santosh is there, my colleague. I'll just ask him to come to set and sit with me. So what I wanted to say is that the question is, what is subintimal angioplasty? Remember, this section is more about it's difficult to teach you subintimal. Basically, if you take the wire subintimally, it is subintimal. That's all. So that is, and otherwise you stay through the lumen, it is an intraluminal angioplasty. So I hope it's, I don't know how clear it is, but I'm just trying to explain it to you. Okay.
Okay, sir. If there are none questions, then I'll ask a few questions, sir. Actually, if there is a metal needle and you have put the Tenemo guide wire, can we remove? I mean, will it the cover will peel off? Is there any chance of peeling?
So the question you're asking is, if metal needle. See, technically, that's the problem.
Yes, sir.
It can peel. So in that case, when you push, there is no problem. When you pull, there is a problem. So one simple thing to do is push it out. And if you have crossed the lesion, pull it along with the needle. You understand? As one unit. Don't pull the needle alone out. That means you push the wire by say 50, 60 centimeters. Now pull the 3 inches of the needle out and then pull it out of the wire. It's safe. Otherwise, flatten the needle as far as possible so that it's in line with the wire and take it out. But it can peel the outer sheath out, yes.
Okay. And regarding if you told about the pigtail catheters, sir. Supposing if you want to do the angio of the pediatrics, where the diameter, what I understood is the diameter of the pigtail is 1 centimeter radius. If the diameter of the aorta is less than, or any vessel is less than 1 centimeter.
So we don't use a pigtail, you just use a straight flush catheter.
Okay.
You can use a catheter a straight flush, that's it.
Okay. And one more thing, if the catheter, on catheter, there have been mention of that pressures, kilopascal, which are allowed. Is there any importance of all those things? Pressure injectors.
Yeah, actually 1200 psi is written over there. So basically, you shouldn't take the catheter pressure higher than that.
Okay, if you set the pressure higher than, then what will happen, sir?
Honestly, none of the injectors work at that pressure. Yes. So you don't have to worry. Theoretically, it'll rupture.
Okay.
In real life, what really happens is that doesn't happen.
Okay, sir. One more thing, and you told about Robert uterine catheter. If it is wound in a 2-3 loops, as you said, how will you tackle that problem?
So remember, is the tip fixed or not fixed?
Yes.
So suppose you are already in the internal iliac artery, nothing to worry. Carefully look, keep torquing, it will open. Because one end is fixed. Don't push it into the aorta. Now when you rotate the catheter, the whole unit starts rotating. So if you think it is getting knotted, don't panic. Make sure your catheter is pulled down deep into the internal iliac and slowly torque and unfold under vision. That's all. If it has come out, God help you.
If it is there is a broken catheter tip, how will you manage, sir? Will you,
broken catheter tip?
Yes, sir.
You'll take a snare and pull it out. But nowadays you can't break a catheter, all braided.
Okay, sir. And one more thing, where do you park the tip of the guide wire? Is there any guidelines are you practice so that where do you park the tip?
where you park the tip of the catwire and depending on which situation you're doing.
Yes.
Suppose you're doing a renal angioplasty and stenting, make sure it doesn't in the tip of the vessel will perforate. So at least give 2 to 3 centimeters gap. If you're working in the brain, don't put it on a bend because it can, so keep it on a straight segment. So basic rules, don't keep it on a bend, don't go very distal, don't keep it near a small branch where suddenly may enter into a branch. Yeah.
Okay. And is there any concept of what about the flappy end? What is the length and is there any relation? Is it practically?
So remember the length of the floppy end. The floppy end's advantage is it allows you to cross tortuous anatomy. Okay. At the same time, the problem, it gives you less support. So if you are going to do a procedure where the floppy end is going to be outside the bend, it will be dysfunctional, no use. So renal artery, your floppy end should be at least 50% the length of the renal artery branch.
Okay. Sir.
Get what I'm saying? So that at least there is 2 centimeters of stiff component outside.
Okay.
Same part wherever you work. It's a simple philosophy that makes sure, for example, if you want to go into the arch and you want to enter into the left carotid artery, you can't have the floppy segment hanging outside. It should be deep in the carotid.
Yes, sir.
So just look at it that way and match up and do it. Yeah.
And is there
Understand the physics of why things move and you won't have a problem.
Sure, sir. And one more thing, is there any difference between the French, like 6 French catheter, guiding catheter and sheath? Are they, what are they, is the inner diameter, outer diameter, at least for the resident, I mean, fellows?
Basically, 6 French is an outer diameter is 6 French. 7 French, outer diameter is 7 French. So as
but in guiding catheter, sir, guiding catheter is the inner diameter or the outer diameter?
For everything, it's outer diameter. For the sheath, it is the inner diameter.
Yes.
For catheters, it's outer diameter.
Yes, sir.
So
That is the
outer
message I am
diameter
getting.
matches the inner diameter. Yeah.
Yes, sir. And it was really a wonderful lecture, sir. And I hope everybody enjoyed. I could see so many comments appreciating your lecture. And I should really thankful to you for accepting this lecture. We hope to have many more lectures from you. I'm really, my gratitude to all ISVR team. Is there any more questions?
Dr. Mathew, can I have a question?
Yeah, who's that?
So I'm Dr. Arun Gupta.
Hi, Arun, tell me.
So, sir, basically,
Arun,
slightly
just
about
one simple thing I want to ask you. What do you think about this format rather than the PowerPoint for something like this? Does you think it makes a difference?
So I think for these practical sort of topics, I think this is very
Sir, your voice is breaking.
Present. There is no need of PowerPoint, and actually, it is sort of hands-on. Are you able to?
Yeah, now we can hear you.
Sir, it was a perfect lecture. Actually, we would like to have such lecture instead of PowerPoint. Actually, this is what our intention and our because it's the masters who are teaching. Because we'll get all these PowerPoint everywhere, but it's the masters which
also we should try this because we thought it. You can actually imagine that you're actually holding it and seeing it. That's why we thought we'll show it. Maybe should we match the PowerPoint after that? I'm not sure. Yeah.
So, Dr. Mathew, one question.
Wires and all, unless we do what we did today,
Correct. So, you have discussed about the double lumen guiding catheter because I'm not aware of any of these.
Not double lumen. The lumen is single, but 2 devices can go through it.
Okay. And one more thing.
So what we use is we use a WY connector. So Y connector has 2 ports for taking devices. We didn't keep it this here, but.
And so one more thing.
Y connector is there. This is a W connector.
Okay, got it. And one more thing. In practical scenario, in which situation you will take the neuron, and in which scenario you will take a Navion for cranial procedures?
Yes. So for us, for every case, we take the Navion if it is available, because it's a far superior catheter. So we believe in the cath lab to keep an inventory to the lowest. So without any doubt, Navion is the most superior catheter. So in every chance, we'll take a Navion. So honestly speaking, we didn't talk about long sheets. There are some extremely good long sheets also today. For example, it's astounding to see how a long sheet called the Cerebros works from Cordis. We can take a 360-degree loop with a long sheet in the internal carotid artery. So Navion is definitely a superior distal access. So there is no difference in price. So if it's a straight access and I want to place it at the point of the, at the point where the petrous becomes the cavernous, we can take the Navion also. I mean, the neuron also. But otherwise, whenever it's very tortuous, we always use a Navion, always.
So can you explain the concept of buddy wire to at least our attendees?
So now see, buddy wire basically means a wire that works like a friend.
Yes.
It doesn't actually do the job, but it is a friend, like a stepney. So there are many places where you can use buddy wires. For example, you have got a tortuous anatomy, say a very tortuous carotid artery, you want to stent, and you find that the device is not going, you want to straighten the vessel. So you can take two wires till the device crosses. So once you have placed a stent across the target position, you take out the second wire and do it. But we have a technique we sort of, I think, developed in our center where we use a buddy anchor technique. That's a very interesting technique. Remember, this is very simple, but very good. Suppose you've got a very tortuous innominate artery and we want to take a catheter of the carotid. The headache out here is when you take your long sheath, it'll slip and fall out. So what we do in this case is we'll take a wire like a V18 wire very deep into the subclavian artery, right down to the radial or the ulnar. Then we take a long sheath over this and we position this in the lower part of the innominate artery. Now it's so well anchored that nothing can move. Then through the long sheath, we will take a catheter wire and enter the carotid. Then we'll push the, what do you call the catheter into the external carotid artery, take an extra strip and position it there, then pull out the wire from the brachial artery and push the sheath up. I hope you understood it.
Yes,
it's called a distal anchoring technique. So it anchors the long sheath and keeps it at the innominate artery till the diagnostic catheter and the extra strip wire is reached on the top.
And what about the concept of weights are like BMW, BHW wires, weight of the tip?
Actually, I find this whole thing crazy.
Yes.
Different companies, Cook makes weighted wires.
Yes.
The other company is called extra support wires.
Yes, sir.
So please use a wire that you're comfortable with. I think in our place, the most popular wire is the command wires. Okay. Command 14, command 18 from Abbott. We also use a V18, even now it's an old wire. And just get used to some one or two wires and you'll be happy. Cook makes weighted wires, same name for stiffer. The tip is stiffer and stiffer, that's all.
Really wonderful, sir. I should really thank from bottom of my heart because it was really, you can see the comments from various people, all are really, appreciated your talk. And we are extremely delighted to have this tremendous response. I thank all the participants for taking the time out in this weekend.
What is meant by forming a loop of SIM1? That is creating the SIM1 shape inside the arch. And then enjoyed a good talk. Thank you. No questions.
Yes,
okay. Sir. So thank you, Gupta ji. Thank you so much, everybody. It's very late for us. We're still in the hospital because I can't work without the assistance of Dr. Santosh to hand me all the catheters and everything.
And you have wasted so many catheters for demonstrating our participant. That's also.
But honestly, without Santosh, you can't do it. Because he's been actually, he planned this whole table for me, and the lighting, cameras, everything. We were trying to do a slightly different technique. We wanted the iPhone to work as the zoom camera, but it failed because the camera there is far superior, where we could actually zoom and show you. But it's okay, it doesn't matter.
Thank you, sir. Thank you very much, sir. And now I think I should thank Dr. Mathew Cherian for this wonderful lecture. Our next masterclass will be on stent by Dr. Roshan Pant, which is scheduled on 11th June. And please attend in large numbers because our main is to spread the academics so that our efforts will have a fruitful result. And thank you, sir. Now it is the time to end. And now it's already.
Bye. Good night. Thank you, everybody.
Thank you, one and all.
Good night, sir. Thank you. Thank you.